shoulder. So the shoulder is one of the regions and one of the joints that, to constitute a full exam by the AAUM standards, we need to evaluate the whole joint, not just in regional terms as we've done with the hip and the knee and the elbow and the hand and the wrist. So starting in sequence, we're going to start with the biceps long head, and we're going to view that in two planes. And second from there, we're going to move to the subscapularis, view that in two planes, as well as dynamically, and look at its relationship underneath the coracoid, make sure there's no effusion and that sort of thing, and we'll watch the shoulder internally and externally rotate and look for the quality of tendon gliding in that view. And then we're going to move laterally and posteriorly and look at the infraspinatus, its insertion and footprint, as well as slide back posteriorly, identify the muscle tendon junction. And in that view, we're going to look at the posterior superior rim of the glenoid labrum and look at its quality of gliding and its relationship with the humeral head dynamically. That's the one view in the shoulder where we get a decent picture of the labrum. And next, we'll reposition the patient and look at the supraspinatus and the anatomic footprint of that tendon. And that's where we're going to see most of the pathologies. And when you get out in these clinical applications, you start applying ultrasound in your practice, you'll see the majority of your shoulder issues. If it's a rotator cuff problem, you will see most of the issues at that insertion. And lastly, the acromioclavicular joint, we will look there. And additionally, we will also, and this is not part of the standard exam, but sometimes when it's clinically indicated, we will take a look at the coracoacromial ligament and look at the quote-unquote roof of the rotator cuff. We can see a lot of problems there, maybe hypertrophic changes of the ligaments, some bursal adhesions underneath it. And nice part about the dynamic aspect is we can put the patient in certain testing positions in viewing those things. So we're going to start with the biceps. We like to start in short axis. Okay, so let's identify where the bicipital groove is. Sometimes with these patients, so if you look, patient's really at neutral in this position, and see how the groove sits off laterally. So let's just internally rotate his arm and find it so we get it more central in the screen and get it more parallel with the beam of the transducer. So in this view, I'm right at the proximal aspect of the groove. Okay, here's the bicipital groove starting to form. Medially, this is the lesser tuberosity. Now laterally, this is the greater tuberosity. And this structure right in the middle is our bicep tendon. I'm going to move distally